For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 9 of Surfing the NASH Tsunami, Louise Campbell's discussion of the role nursing professionals can play in support of the entire NASH and NAFLD treatment and clinical trial process starts now.
This week on Surfing the NASH Tsunami.
The health inequality is so vast in terms of people with liver disease generally. When we review the data and we see also the correlation of COVID and again that health inequality, we're nearly mirroring in terms of our liver patients that health inequality that the COVID patients have also had. We've somewhat been blindsided, and when I say we, I mean the population, the policymakers, everybody's been blindsided by actually all of a sudden we've got a massive problem in terms of people at risk and with liver disease, and unfortunately that is being replicated across the world.
Health education and information is just as much a valid part of nursing care as checking pressure areas and giving out medicines.
We've got all of these great drugs, but we have no people there to locate disease early enough to stop them needing those drugs. My concern is if we don't have this expertise on the clinical front line, we can't have that discussion with people for early diagnosis. We can't have that discussion to get them into trials.
We talk a lot about physicians talking to other physicians and physicians talking to patients and physicians talking to payers and legislatures, but not making a combined effort with our nurse experts in this regard. And I think it's absolutely critical because, as you mentioned, we're only one person, we're only one specialty group, and we need to combine forces.
Every week, a global community of fatty liver disease stakeholders comes together to explore the most important challenges in diagnosing, treating, and developing medications for patients with fatty liver diseases. Join hepatology researcher and key opinion leader, Dr. Stephen Harrison, liver wellness advocate Louise Campbell, and this week's guests, nursing key opinion leaders Kathryn Jack, Patrizia Kunzler, Pam O'Donoghue, and Michele Clayton, as they discuss the roles that advanced nurse practitioners and liver nursing specialists can play in prevention, early stage management, and clinical trial recruitment for NASH and NAFLD. Today on Surfing the NASH Tsunami.
Hey there, welcome to this week's edition of Surfing the NASH Tsunami. This week should be a bit different for all of us. It was different for me because while the episode was being recorded, I was away on a long weekend somewhere far warmer than New Hope, Pennsylvania, with no cares in the world, or at least no cares for this week of the podcast. It was different for Louise because this was her podcast to plan, to invite guests, and to moderate. As you're about to hear, she just did a fantastic job. And it will have one more difference for you as a listener. The episode focuses on the role that liver nurses and advanced nurse practitioners can play in the entire range of key NASH and NAFLD support activities, ranging from patient education and management in the earliest or later stages of the disease to helping recruit for clinical trials. Listening to this episode was the first thing I did when I started back to work this morning, and if anything, I'm even more energized after listening than I was when I started listening 2 hours ago. This episode's different in one more regard. For the first time in a while, a patient wrote in not only to thank us for the podcast, we get letters like that from time to time, but seeking specific guidance on her own situation. At the beginning of this podcast, Stephen Harrison fields and addresses her question anonymously. If you are a patient listener, and I know we have a bunch of you, with questions about your own situation, feel free to write and let us know whether you would like us to issue an anonymous public reply, the kind of thing Stephen's about to do, or a private response. In either case, we'll be happy to comply. So, without further ado, here are Louise, Stephen, and Louise's guests for the day. Enjoy, and I'll be back with the business section when they're done.
And welcome this week to Surfing the NASH Tsunami. Now, Roger Green has left it in my capable hands, but that could be very dangerous because Stephen and I are let loose on the ranch. And with us this week, we've got a nursing special to bring the dynamic of nursing to clinical trials, to the care of patients with liver disease, and particularly the care of patients with NASH. And we're hoping that we'll be able to share some expertise, look at clinical guidelines, competency documents that can be utilised in any area around the world. So we're looking for an interesting debate. So I've got Michele Clayton, I've got Patrizia Kunzler, I've got Dr. Kathryn Jack, and I've got got Pam O'Donoghue, who is having some technical issues, but she will be joining us, I hope, shortly. And obviously, we've got Dr. Stephen Harrison. Good evening, Stephen. You and I are let alone on the ranch.
And I'm so glad you're in charge of this episode, Louise. You command authority and respect from all corners of the planet. So you're getting mine from San Antonio, Texas, and it's happy. I'm just thrilled to be here to learn from you and your colleagues, because there's so much that we don't talk about relative to the nursing side. And I'm just looking forward to hearing that perspective today. So I've been itching for this episode, and I'm glad it's finally here.
Fantastic. Nothing like something to live up to, ladies. So what we're going to do first is we received an interesting question from a patient in the US, and Stephen's just going to run through that before we introduce our guests properly and they tell us a little bit about themselves. So Stephen, over to you.
So we are thrilled that we have a question that came in from the audience, and we encourage people to continue to write these questions so that we can understand exactly what's going on out there and what your concerns might be. So this question comes from a lady who reports that she has NASH cirrhosis, diagnosed with a liver biopsy in 2012, so about 10 years ago. She has a past medical history significant for metabolic syndrome, including type 2 diabetes, diagnosed in 1995, high blood pressure, hyperlipidemia, and is also a little overweight here with a BMI of 38. She also has polycystic ovarian syndrome. In reference to her NASH cirrhosis, she is well compensated. She does have grade 1 varices. She is on Nadolol with a pulse in the 50s and 60s. Her platelet count is around 125,000, and she reports it's gone down a bit over the past 2 years. In reference to being compensated, she has no hepatic encephalopathy, no ascites, no sarcopenia. So generally, she feels well. She's on an insulin pump with an A1C of 7.1, and she reports her weight has always been a struggle. So she is really looking for information to help advocate for herself and to understand how her choices affect her health. And very thankful to listen to the podcast. She says she often listens to the podcast while cooking dinner. Thank you for helping the world realize that we are at the stage in the tsunami where the water is being pulled out and it will soon slam ashore. I think that's a wonderful case vignette to talk briefly about. And I think you're doing all the right things so far. You're managing your comorbidities. You're getting a hold of the diabetes and trying to drive down the A1C. You're on insulin. One thing you didn't talk about was, are you also on additional anti-diabetic medications? And the one that we know could be helpful in this particular situation, actually there are probably a couple. One is pioglitazone. Now we have to be careful with pioglitazone with weight gain, but at doses of 15 milligrams per day, that might be a place that could help you. And then of course the GLP-1 agonist, which could also have the beneficial effects of some weight loss as well. And then potentially an SGLT2 inhibitor. In reference to additional things that you can do, we talked about the struggle with the weight and maybe dietary modifications. And one of the diets you had mentioned is that you had started a whole food, plant-based, no oil approach to eating and hoping to reverse the diabetes or at least get off some of the meds that you're already on. I'm personally not familiar with that particular diet. I can make two observations. Number one, we know that carbohydrates are converted to fatty acids and are delivered to the liver in the setting of excess nutrients. So we want to be careful in eating carbohydrates. So I tell my patients, cut out the bread, rice, pasta, pizza, potatoes, tortillas, that sort of thing. And to also increase your exercise to the ability that you can, both in building lean muscle, so in weight training, and also aerobic in walking or riding a bike or a row machine or something along that line. And you can have little watches now, either Fitbits or Apple Watches or whatnot, that can track the number of steps you do. And you want to know how many you're currently doing. Let's say it's maybe 1,500 to 2,000. And then you want to try to double that and then triple that number to try to get to 10,000 steps a day. All those are additive and helpful. As far as things that don't really help you much, I would say there's a lot of people that come to me asking about milk thistle, turmeric, coumarin, things of that sort. None of that has proven beneficial in driving down inflammation. Oh, there's one thing I want to talk about with fats. You mentioned working with the no oil approach. So one thing we are learning more and more about is that triglycerides, or specifically omega-3 omega-3s and omega-6 fatty acids, there's a ratio that's better for people with fatty liver. And that is we want to have low amounts of omega-6s and high amounts of omega-3s. When you do that, you shut down arachidonic acid cascades, drive down inflammatory responses, and that ultimately should have a positive impact on your liver health, including the scarring and fibrosis. Remember, the liver heals just like the skin does. When you get a cut on your skin, you form a scab. When you injure the liver, you form a scab. We call it scar tissue, not a scab, but it's essentially the same thing. It's not bad for the liver to have scar tissue. It helps the liver remodel. We only get into trouble when we don't take away the insult that's driving the injury that leads to the accumulation of scab over time, that once it gets so severe, it begins to cause the liver to not function properly. So that would be important. The final thing I would mention to you relative to diet is coffee. There's a ton of data out there now supporting the use of regular drip coffee, and probably because of the phenols in the coffee bean itself that are helpful. So 2 to 3 cups a day, as long as you don't have a history of atrial fibrillation or some sort of dysrhythmia, you're probably going to be okay. Remember, decaf does not work. That's what I would tell you to do. And also be alert to new options for pharmacotherapy. You know, our drug development pipeline is robust, and we are hopeful to have our first approved drug within a year and a half or so, ideally. And if you're eligible or can get into a clinical trial for cirrhosis, I would advocate for that also. So let me stop there and turn it over to the experts here and see if, Louise, if you or the team of your colleagues have anything to add.
I'm sure we'll have some to add a little bit later, because we're going to talk about the nursing care and the perspective of that. Some of what she commented on about lack of awareness in different specialities, we might be able to touch on lack of access to people who know about the disease for care as well, for example, we might be able to do. What I'm going to do is, we've now got Pam on board as well, who's joined us. What I'm going to ask is each person, I'm going to read your names from my screen going round and ask you to just give detail 2 or 3 minutes about yourself and one fact, because we always liked our one fact most people wouldn't know about you. So some of these I'm going to be very interested in. I've known most of these guys for a very long time in different guises, and some of these I don't know. So Michele Clayton, introduce yourself. Tell us where you come from and your skill set.
Thank you, Louise. My name's Michele Clayton. I work in Leeds in the United Kingdom. I've been a liver nurse for many, many years. I was just thinking about it, and approximately 30 years now. And I've really enjoyed my liver nursing career, and one of my big focuses is around liver education for nurses. So I've worked at King's a number of years ago, and then the rest of my career I've been in Leeds, and that's either been on the Leeds Liver Unit or at the University of Leeds, where I do a sort of part-time lecturer role as well. One of the things for myself is that really tried to promote liver nursing within the UK and also European-wide as well. I've been involved in the British Liver Nurses in the UK for many, many years and became their first elected chair of the new organisation, the British Liver Nurse Association, a couple of years ago. And I've really been privileged to have that role and also to forward nursing within the European Association of the Study of the Liver, where I became their first chair of their Nurse and Allied Health Professional Task Force. I think for me, one of my big achievements has been I co-wrote the Royal College of Nursing competence framework, and it's back in 2013, and we've now updated that a number of times. I think we're on our 3rd iteration of it, and I wrote those with Linda Greenslade, and they've been really there to promote professional standards for liver nurses, and I think that's a really important aspect, that we ensure that we have quality of care and that is consistent across different liver units, hospitals, etc. So I'll finish there, and I'll give you something you might not know about. So I ran a girls' football team for 10 years. I think most of the other parents stepped back and I was left there. It was really enjoyable and we had a lot of fun over the years. So thank you.
Michele, I was in the military for 21 years on active duty in the United States Army. And one thing we were taught early on is never volunteer for anything. So what happens is you don't have to volunteer. It's just everybody else takes one step backwards and you forget to take a step backwards and you're the only one left. So it's a similar situation to yours as well.
Absolutely, Stephen, yes.
Michele's done that a lot. Okay, Patrizia, tell us a little bit about yourself and your background that you bring into us.
Yes, thank you. My name is Patrizia Kunzler. I'm a Swiss registered nurse. Hopefully I can follow the conversation today as I'm not a native speaker. For 25 years, I work in the clinic for hepatology at the tertiary hospital here in Switzerland. And in parallel, as I could not study nursing science in the beginning, I started some years later and I have done bachelor master degree as well and completed my PhD in 2020. So in my older years, I have started to doing my own clinical research and I really like to do this. I would say my greatest interest is in new models of care, especially for patients with liver disease. And I'm happy to have a good colleague in another hospital in Switzerland because we are the only ones here who are specialized nurses in liver disease. And so we are developing and testing now new ways of nursing in liver care. Our focus but is honestly on liver cirrhosis and liver transplant at the moment, but we can go into discussion later why we are not involved earlier stages of patients. What an achievement is during my PhD, I have done research in behavioral change and coming to a healthier lifestyle. We have developed and tested a behavioral intervention for men who have sex with men that they can reduce sexual risk-taking to avoid reinfection with hepatitis C. So you see, I'm coming from an infectious disease side, but I'm sure it's a very good knowledge I have about working with patients and how they can change their behaviors. Meanwhile, I have developed an advanced practice nurse role in Switzerland. I give lectures for students and I'm also involved in patient-centered communication workshops we are doing for healthcare providers. And this is really where my heart beating as well. We need a good communication, especially when we want to work with patients on behavior change. Something about me you probably not know. I gave birth to my son at home, and this was not because of mistrust to the hospital or the midwives, but it was unexpected, and I was happy to have my husband helped me through. So yeah, that's the family story here, and all start to laugh when we speak about.
Well, that beats running with the bulls in Pampaloma, I have to say. Having a baby at home with your husband. You did know you were pregnant.
Oh, I did.
I do hope so.
Yeah.
That gives new meaning to the word date night.
Yeah. Absolutely, go for it.
I'm not sure if my husband would take me if he knew that he has to be the midwife.
Fantastic. Moving on now, Pam, come and tell us about yourself.
So I'm a senior hepatocellular carcinoma clinical nurse specialist with a 22-year history of working within this field. I originally started as a hepatopancreatic biliary clinical nurse specialist, but I had the opportunity to subspecialise into HCC about 12 years ago at the Royal Free Hospital in London because of the huge volumes of HCC patients that were coming through at that time. Some of the interesting things I've done in my career, I set the joint hepatocellular carcinoma clinic up at the Royal Free Hospital about 10 years ago and streamlined the whole service so that patients weren't going to hepatology clinics, oncology clinics and surgical clinics. It was a one-stop shop on a Monday, and they would see all the consultants in the same clinic, either jointly. Sometimes they would see 3 consultants together, 2 consultants together, and they would have all their up-to-date imaging done that morning. So we had up-to-date imaging available for the consultations. And the idea was that when they left that clinic, that the next time they came back to that hospital, that was for a treatment. And we published the outcomes from that clinic, which were quite impressive in terms of reducing the waiting times from diagnosis to first treatment. And we saw a huge increase in the number of patients going on to have curative treatments like RFA and resections, and even getting into clinical trials, because previously it would take months to get through all the different specialities and for consensus to be agreed. I also set up the sorafenib nurse-led clinic at the Royal Free Hospital and audited the outcomes, which showed actually with good senior clinical nurse specialist support that actually dose intensity and duration on difficult treatments like sorafenib daphne can be improved dramatically with the input of a clinical nurse specialist as well. Prior to COVID, in January 2020, me and my colleagues from King's and Birmingham managed to get all CNSs in the UK who were involved in looking after patients with HCC. And that was a wide range of different types of CNSs, hepatology, HBB, GI, OG. I mean, it was completely different wherever you went. And we got everybody into the room. And at the back of Michele and Linda's fine competency work, we set out to establish what were some of the specific dimensions or competencies that HCC CNSs would need going forward. And we managed to kind of draft and get a consensus on what they should include, which would be immuno-TKIs, radiation, genetics, functional management, holistic needs. I had a medical writer writing up some of the initial ideas, and then it all got kind of stalled with COVID, but hopefully we can get it back off the ground at some point in the future so it could be used not just in the UK, actually worldwide, because I think wherever you go, the HCC patients are looked after by a variety of different types of nurses. Something interesting about me, I don't know if it's interesting, but I cycle a lot. I've done London to Paris, I've done Le Tap and cycled up Val Thorens, but I don't think that's terribly exciting, but there's nothing else, so...
Oh, I don't know. I cycle around the block, so you beat me. Thank you. That's a wealth of knowledge. And finally, into Dr. Kathryn Jack. Tell us about yourself.
Hello. Thank you, Louise, very much. Yeah, most people know me as Kate. I feel like Kathryn's my Sunday name when I'm in trouble. I came to the world of viral hepatitis back in the year 2000, and I work in the East Midlands of England. So I'm now in Nottingham, which is home to Robin Hood territory, really. A lot of the work I've been involved in Nottingham has been around taking hepatitis C treatment out into the community. And certainly in the early days, in the earlier part of 2000 and 2005, we began to take some work out into GP practice and assess people who were still taking drugs and get them onto interferon and ribavirin, which at the time was a little bit controversial, but we were able to demonstrate very easily that nurses were very capable and just as adept at doing that as anybody else, and that the SVR rates were the same and patients responded well. As time's moved on, I've retained a lot of interest in viral hepatitis, and that's really where my expertise has sat. Like Patricia, I was able to do a PhD, which I got in 2019. And my work for that was to evaluate the impact of the opt-out testing system for hepatitis C in the prisoner population. So I describe myself really as a mixed methods researcher, and I like doing, a whole variety of different complex methods and weaving them together, trying to support the decisions that patients make. As I say, I work in Nottingham. I work with a team of 4 other really fantastic nurses who I feel very privileged to work with, and we have some great consultants, and we also have pharmacists. We have a dedicated pharmacist and a pharmacy technician with our team as well, so a lot of emphasis on our wider AHP colleagues as well. In terms of something a bit different about me, the only thing I do on my days off sometimes is ballet, which usually makes people laugh because I'm not really skinny, but I don't wear a tutu and I can't do the splits, but it's all good fun.
Fantastic, and it's increasing exercise. This is one of the reasons that I wanted you guys to join us. When we talk a lot on the podcast, Steve and myself and all of the other guests, about care pathways for liver disease, but specifically NAFLD and NASH. We talk about comorbidity management. We talk about its interaction with all of the other diseases, because we don't tend to ignore them, but we do tend to see ourselves ignored in the way back. And I think you 4 have highlighted really, really well the sort of breadth of nurse specialists and nurse consultants bringing a different dynamic to the care of patients. So to design any pathway for liver disease, it is absolutely intrinsic that we look at where we can best utilise nursing care to its maximum. And now that can be in different settings, it can be different regions of the world. So that was one of the reasons that we wanted to do the podcast this evening, as to how we can share those strengths, how we can get people to think outside the box. A nurse is a highly undervalued, underutilised tool in a lot of areas, and helping your nursing teams develop could be one of the biggest things that we can do for any patient in liver disease care. And we've seen it in diabetes care, we've seen it in gastro IBD nurses and cardiology. So what I wanted to do was raise the question of, we've recently had the Lancet Commission report published just before Christmas. Now, there's 2 areas of that I wanted to start with today, but we'll start with looking at health discrimination. You've detailed very well, all of you, how highly regarded and how high we can put nurses into the chain to help look after liver disease patients, from HCC to competencies to helping the care to hepatitis C in prison communities, hepatitis C and behavioural change in men who have sex with men, for example. So when we talk about health discrimination, we talk about most of the population of this country, UK specific. Patrizia, you'll be able to comment on this, going into a hospital, being admitted and not having, if you are not in a liver unit area, any single person who knows about your disease. And I participated in the NCPOD report, and we only rated 47% of people who got care for alcohol-related disease, end stage, as even good. So I'm going to start with Michele. Do you think we discriminate in where we place patients? How can we change that? And what are your thoughts on it? Because you've done an awful lot of work with the competency documents to try and improve that.
Thank you, Louise. What I would say is, and when I listen to you, it strikes me that NCPOD back in, I think it was 2012, 2013, published the report measuring the units. And that very clearly stated that patients who were admitted with alcohol-related liver disease, normally in a decompensated episode, were poorly treated in terms of the access they received. That might have been because there wasn't a specialised hepatologist within a district general hospital, or even a gastroenterologist that had some interest in hepatology. And it's interesting that we're probably about 10 years on, and I think in some respects there is more interest in hepatology. We've seen a lot more clinical nurse specialists being promoted into roles within district general hospitals because they have had a gastroenterologist with an interest in hepatology. So we're starting to see some of those issues chipped away. Realistically, when we look at it, we have to go much wider, and we have to go back to the fact that to be able to tackle liver disease, and it's reflected very clearly in the EASL Lancet paper that's just been recently published, is that the health inequality is so vast in terms of people with liver disease generally. When we review the data, and we see also the correlation of COVID and again that health inequality, we're nearly mirroring in terms of our liver patients that health inequality that the COVID patients have also had. So I think there's lots of work to be done, particularly on more a population-based level, but we are starting to see some improvements, but that's not consistent. And that's where we have to continue to promote clinical nurse specialists within the liver environment. We should never forget that nurses are actually the largest workforce in healthcare in whatever country, and actually having those nurses trained to identify risk factors for liver disease is also tremendously important, because we have to think we have a tsunami now of liver disease. We need to prevent the next generation as well. So actually utilising nurses, training them up to recognise what those risk factors are and start to do some behaviour modification is really, really important.
Thanks. Patrizia, Switzerland, what's the level of competency on the wards? Do you think there's a good level of nursing knowledge across to provide care?
That's a difficult question. I would say when come patients in contact with nurses when they have a liver disease, in Switzerland it's quite late. It's when they arrive at the hospital with a proven liver disease or the decompensation, and then we have to say we have very good nurses, we have wards with specialized nurses, and we have, as I said before, we have also advanced practice nurses who take care for this patient group. But before, on the prevention level, outside on a population level, I would say in Switzerland the nurses are not involved. Here we have the medical hierarchy cardiology. I don't know how to say it. So physicians are in the general practitioners are involved, and we have no financing for nurses on that level. So probably you can say if you enter the hospital and you arrive on our ward, then you can be happy because you have access, but otherwise it's very difficult.
Kate, anything to add to what Michele and that said?
May I just say, in terms of, I agree with Patricia that it's probably reflected around many countries, and even in the UK, that there is this wealth of opportunity in terms of getting nurses to identify risk factors in the population, but it hasn't been necessarily recognised in, as you call it, that hierarchical perspective of the medic. They see nurses still within certain parameters. That's what we need to be changing. We need to be standing up and really using our voice to say, we can help you. We can actually make a difference. What you need to do is invest in us, and then we can start to actually utilise our skills to change this population level perspective that we've got with liver disease at the moment.
Yeah, absolutely agree on that.
With the view on inequalities, this is where there are sometimes not enough specialist nurses to be able to serve the populations as well. And although England is a very small country and it's quite densely populated generally, there are still pockets of England that are very rural and don't have easy access to healthcare. So I'm thinking Cornwall, Lincolnshire, Cambridgeshire particularly. And these are parts of the country where people may need to drive, 2 hours to get to their nearest hospital. So one of the things that we've certainly done and we've been advocating throughout England is having nurses who can be more community focused. So we're employed by the hospital and part of the medical team as normal, but we are able to travel out and meet people. And certainly this has worked with viral hepatitis in that we've been able to send staff to go and visit different community drug teams in small pockets in small towns and do testing and identify who's got a problem and then treat them. A lot of places have access to portable FibroScans, so the nurses can take those out and complete the whole assessment and have a really meaningful health education conversation at the same time and bring it all together. So, the impact that a nurse can have is very strong. With regards to ward nurses, I suspect that we're probably similar to other countries in that there are fewer nurses available and the patients in hospitals are much more acutely ill than before. So it becomes quite hard and quite challenging for nurses on the ward to actually sit down for 20 minutes with a patient and say to them, do you understand why you're here? Do you know what cirrhosis means? Do you know what you can do to make life better for yourself? Do your family understand? And all of these opportunities have been lost. And it's a time really to start calling for more nurses, as Michele says, to have a stronger voice and to start to collectively put this back on the agenda, that health education and information is just as much a valid part of nursing care as checking pressure areas and giving out medicines.
Yeah, and I think you all make an excellent point, is that also that people are becoming sicker. I think, Stephen, one of your recent publications was that although cirrhosis wasn't necessarily increasing, it was the decompensated cirrhotic population that was increasing. Now, obviously, that's where PAM comes in with the liver cancers and that. Even from a liver perspective, we would see that a liver cancer unit is highly specialised. So, Pam, do you have any issues with knowledge? You probably have a high level of knowledge within there to support your medical colleagues with this.
I mean, I can't seem to shift my mind from the kind of current state of affairs on wards. And I know that won't last forever. And, patients on the wards are extremely unwell. Cancer patients are presenting at really late stages. Wards are short-staffed. And I just can't see how ward nurses, as much as it would be great if the patient-nurse ratio was a good number and they had time to sit down and say, do you know what your cirrhosis is? In the foreseeable, I can't see that happening. I just can't see the ward nurses being able to have that time with patients. So then, of course, it potentially all needs to come back onto clinical nurse specialists and perhaps more clinics, not necessarily at the centres, maybe a bit more outreach where you're going out to the hospitals or something virtually. Because, of course, one good thing that COVID brought us is the virtual potential going forward. Everybody's a lot more amenable to it now, and especially patients and families. They've had 2 years of video consultations, and I think think there's a great opportunity here to utilise that more. My fear is we're not going to achieve much on the ward front, I don't think, and somehow we need to bring it back out onto the nurse specialists. Just thinking about time as well. Certainly, when I was doing the sorafenib nurse clinic, I could spend an hour counselling a liver patient on management of their side effects from sorafenib. And I understand that the newer treatments like the immunotherapies have a lot less side effects, but nonetheless, when they do get effects from those treatments, they can be extremely serious. So they have to be counselled to the same level at the start. And you would spend an hour and a half with a family and a patient. And in the end, A, I was sick of the sound of my own voice, but B, the numbers of patients coming through, there was just not enough hours in the day for me to counsel them. So actually, in the end, I did recordings, and I would play the recordings in a room, and then I would go next door and get on with the next patient and come back. So it was also looking at smarter ways of using my time. I wasn't able to expand the team at that time. There wasn't another me. So actually, I had to use my time very, very carefully as well. So I was thinking about, Kate, what you said about when they go out to the houses and do their FibroScans, whether you can leave some sort of video recording with all the advice and the information so that you can get on and do more scans and see more patients, because I think that's where we're headed. I think resources are going to be hugely strained upon for years to come as we recover from this. There's huge backlogs. There's thousands of cancer patients across all tumour types waiting for treatment. I just think time and resources is going to be really challenging going forward. And sorry to be a bit grim about it, but for me, I think it's really important we start to look at more efficient ways of working.
I don't think you've been grim enough.
I mean, I really like the idea of leaving more sort of audio information.
Yeah, I used it it was a saviour in the sorafenib clinic. I must confess as well, there were times when there was 4 or 5 patients waiting for counselling, and we actually did it in a group. If we gained consent from each family and said, would you be happy to join other patients whilst we do the sorafenib counselling? So you had the choice of listening to something audio for 40 minutes in a room by yourself with your family, or you could sit with some other patients. We allowed about 4 or 5 patients in a room together. We did the counselling together, and actually that supported them striking up relationships with each other and supporting each other as well. But there's just certainly wasn't enough time for one-to-one at that point. So we've got to get smarter.
Pam, I'm just glad to know that doctors aren't the only ones that don't have it all figured out. It highlights for me, as I sit back on the heels of the Maestro NAFLD data that was reported this morning from the first phase 3 trial with a non-invasive entry point and a non-invasive exit point, is we're getting closer and closer to our first treatment for NASH. And in your neck of the woods, what that means is very likely less liver cancer if we can get the appropriate treatment into the right hands. And we look forward 3 to 5 years down the road, and we should leave a big fat dent on the planet in the name of hepatocellular carcinoma, at least secondary to non-alcoholic fatty liver disease. That's a big, audacious, hairy goal, but I think it is potentially achievable. And as we begin to craft the narrative around disease awareness and education, I haven't considered the nurse specialist in that paradigm. We talk a lot about physicians talking to other physicians, and physicians talking to patients, and physicians talking to payers and legislatures, but not making a combined effort with our nurse experts in this regard. And I think it's absolutely critical because, as you mentioned, we're only one person, we're only one specialty group, and we need to combine forces. It's like in the military, as I mentioned before, we're not just the infantry, we're the artillery and the Air Force and everybody coming together. And that's how you win a battle, right? The Air Force can't win a battle until they put boots on the ground, right? So the doctors can't win it alone. The nurses can't win it alone. We're going to have to do this collectively. In fact, I'm often wondering now, what else? What other groups are we leaving out that we need to bring into this discussion to help us kind of turn the tide on disease awareness and education?
Well, you're a big advocate of the podiatrist.
No, I am a huge advocate of the podiatrist. My eyes were open when I went to a primary care office to recruit for fatty liver patients for clinical trials, and the primary care docs were running around. They were running late. So I'm just sitting there talking to whoever comes in the door, offering them, something to eat, a sandwich for lunch, and tell me about yourself. And this lady walks in and says, "You don't want to talk to me. I'm just a podiatrist." I said, "Well, that doesn't matter. Tell me what you do. And she goes, well, I actually do have a question if you're a liver doctor. I see lots of diabetic foot ulcers, and I see lots of people with toe fungus, and I want to prescribe Lamisil for them, but I can't until I check their liver enzymes. And I check them, and they're often very elevated, particularly my diabetic patients, and I don't know what to do with them or where to send them. I'm like, well, you're the exact person I need to be talking to. You're seeing the tip of the spear here. You're the folks that we need to be educating. So I wonder, are there other medical camps that we're leaving out? I mean, we talk about obesity clinics, and we talk about cardiology clinics and endocrine clinics. My guess is we probably should be including GYN clinics. I mean, how many women get their primary care from an OB-GYN, and they don't know how to manage fatty liver or even have a conversation with the patient about fatty liver. How many of those patients have polycystic ovarian syndrome, like the case we talked about today when we first started talking, and the link between PCOS, diabetes, and fatty liver? So there's so much we can do, but I think it gets back to the two pillars, the two foundational pillars of education, being the doctor and the nurse going out collectively and developing content and developing strategies for reaching the masses. And at the end of the day, I think that will be a positive feedback loop to you on the ward in managing these people in your particular situation.
There has to be trust as well. There really does have to be a lot of trust between the physicians and the nurses. I didn't just walk into the Royal Free and suddenly set up Serafina Clinic. It took years of working with those consultants for them to trust me, for me to trust them, for them to allow me to do things like that, if I'm being honest. And, even with that clinic, I remember Professor Mayer saying, we will give this a go. This is a pilot for 6 months, and I need audited outcomes. I need to know that this works and it's better for the patient. So close working relationships, trust, audited outcomes, it all needs to be measured. So the physicians feel safe as well. I know historically we've proven we can do things really well, but these are complex patients. There has to be a trusted working relationship to move forward as well.
But what was interesting on what you said there, and linking into what Stephen was saying, if I hear it right, there may be the opportunity to have videos in diabetic clinics about fatty liver disease or polycystic ovary disease clinics. And actually, rather than necessarily try to break the system, because we get a lot of pushback with diabetes care and cardiovascular, but if we had a generic type system where we could show a video, if you've been diagnosed with this, link into this, we could recruit for trials, people get better information, but it also leads us on to, we can share those competencies that you've designed, because yes, they're British centric, but they can be utilised in any part of the world. You can have a video that's thing, you can have consultations now. Hannah's right, and we've discussed a lot on the podcast, we need to use new utilisation of technologies and things like that. So I'm sure, Kathryn, you've done some remote work in and out of the prisons. Do you do it remotely now? Has COVID changed how you particularly deliver that?
Some of my other colleagues do some of the prison clinics on a more regular basis, and over time they've developed some really good working relationships with prison nurses. So once people are tested and diagnosed, the conversation then happens between the prison nurse and my colleagues, and then we can arrange, discuss, get the baseline data that we need and information, discuss it at our multidisciplinary team, and then organise for the prescription and the drugs to be dispensed and taken to the prison. And often prison clinics take place in person, with a nurse going in to actually see somebody and take the FibroScan in and have a complete conversation. But there are times, particularly during COVID, where we haven't been able to actually go into prison because they've really needed to reduce footfall in the establishments. It makes it very difficult to actually see or speak to the people concerned. But because we've built up good relationships over the years with the nursing team there, it's like anything, when you've got good rapport with colleagues in different departments, everything follows quite smoothly. So we have managed that. One thing we have noticed, though, is going on of a very slight tangent, is that although, there's 3 main causes of liver disease with alcohol, fat and the viruses, there is significant overlap between all 3. And certainly with a lot of the patients I see with hepatitis B, for example, I see people and they've got elevated ALT, but they've also got a BMI of 34. And I'm thinking, well, there's a good possibility here that the raised transaminases are not just down to the virus beginning to break through, but down to fatty liver. And so we're needing to assess people differently rather than simply go down the route of offering tenofovir or another therapy for the hepatitis B. So everything is very interlinked, and we need that strong recognition, I think, as well.
Do you have a fatty liver disease clinic in the prison, or is it purely are, or you're there with the FibroScan machine, is it something you could develop?
We've not got anyone doing a specific fatty liver disease clinic at the moment, but it's on the cards. Certainly in Nottingham, the consultants set up a pathway a few years ago now to encourage GPs to refer people in with certain criteria for screening. And this has taken off to the extent that we have quite a lot of waiting list now, and we have a lot of people being scanned on a regular basis. And I've been involved with doing some of those scanning clinics, which are a great nurse-led intervention opportunity, because I can scan people, tell them that they may not have cirrhosis, but they might have a FibroScan of 10 and a very high CAP score for fat, and they're also type 2 diabetic, or they've got polycystic ovary disease and a very elevated BMI. And it's an opportunity to have a very holistic type health education conversation. And it's delivered as a brief intervention. We're not there for hours talking to them, but being able to tell people individually, look, these are your results and this is the problem and this is the risk you're putting yourself at. That's what nursing's about. It's that health promotion. And we are actually identifying people who've got cirrhosis in those clinics who have previously not decompensated and they're not known to us. So we are able to then bring them into the consultant clinics for a proper workup and review. So it's definitely worth doing.
Michele might probably be able to comment on this. Where are we at with the universities? Because obviously now fatty liver and cirrhosis is big news. We're in an epidemic and 40-50% of the population is overweight and obese combined figures. But does that guarantee us more time with the universities for nursing students or not? No.
Well, I can only speak about the UK. Each university in the UK decides what their nursing curriculum is that matches the NMC standards. It will depend on where the strengths lie with the lecturers. So some places will offer liver, some will not. The majority do not. Realistically, even to tackle this for future workforce, again, we need to get back to that public health population level, that it needs to be in people's psyche. People think about cardiovascular health, people think about caring for people with diabetes, etc. And those are very strong public health themes. So we've really got to work at the fact of making liver more sexy in terms of public health, because that's what we always have struggled with, that traditionally it's been a bit more of a niche subject, whereas now actually not recognising it earlier from a population level is leading to these vast numbers of people that are now developing liver disease through diabetes, obesity, co-common diseases. We've really got to get it on the agenda, and there's a lot of work in the UK around raising the awareness in government through the Houses of Parliament, etc. They're doing the Sound the Alarm campaign, which is really trying to demonstrate there is this massive problem. But actually, when you look at things, these problems are replicated across most countries of the world. Doesn't matter if it's Europe or whether it's now in China. There are very, very obese people because of the behavioural change. We've really got to get to grips with this sort of prevention, because, you know, that old adage, prevention is better than cure. And we've really got to go towards that at a population level anyway.
I can say this because I work in oncology, but maybe I'm wrong, but I just feel like we've got so much systemic therapy for HCC now compared to 10 years ago. It feels like it's really got itself into the limelight. And I always feel like that's great and everything, but we're spending billions of pounds on now something like 6 or 7 drugs that will prolong your life an extra few weeks or months. And I sometimes think, why is none of this money being invested way back at the start of the journey where Kate is and yourselves are going out and trying to prevent it from getting to that state? I mean, we've now got atezolizumab, lenvatinib, regorafenib, cabozantinib, clinical trials, SBRT, CERT. I mean, compared to 10 years ago, there was sorafenib. And I feel like all these CNSs are being hoovered up to manage all these patients going from TKI TKI to TKI to TKI to TKI. And I think, but what about the start? It doesn't feel balanced. Is that a fair assumption of mine?
Yes, I think it is fair, actually, Pam. But also, there's been a lot of interest in developing these different therapies. And obviously, from a pharma perspective, some of those therapies allow their companies to profit. If we look at it in terms of our own populations, then if we think back to the UK in the 1990s, there was a big push about the government looking at renal and cancer and cardiovascular. And those are the services now that have reaped the benefits, whereas liver was not described even at that time. But actually, it's been hiding underneath all of this. And then all of a sudden, it's popped its head above the parapet and said, hello, look at me. I am the big problem now. We've somewhat been blindsided. And when I say we, I mean the population, the policymakers, everybody's been blindsided by actually all of a sudden we've got a massive problem in terms of people at risk and with liver disease. And unfortunately, that is being replicated across the world. We used to see it in the US with their stats around obesity, but we're seeing that consistently now across countries that would never have had any issues with fatty liver previously now have those problems as well.
And I think you're right. And what you described there and what Pam has described as a Western society that has access to expensive drugs, where it causes more problems, the lower socioeconomic countries and third world developing countries who will never get access to the expense of those medications. On one hand, we've got all of these great drugs, but we have no people there to locate disease early enough to stop them needing those drugs. And I think that's what Stephen was alluding to. If we can even target that for NAFLD and NASH quite early, my concern is if we don't have this expertise on the clinical front line, we can't have that discussion with people for early diagnosis. We can't have that discussion to get them into trials. COVID, and one of the reasons this podcast started was trials for fatty liver disease were falling by the wayside or failing to recruit. We have liver biopsies that require ballooning, and we've recently discussed how difficult it is in the tissue that we get to see one ballooning site and have histopathologists agree with it to get somebody included into clinical trials. So without a forefront of either nurses, primary care, it sounds from what everybody's describing is it's really difficult to have that conversation because we're not seeing people to be able to talk to them, to be able to get them into trials, to give them access to better treatments. It is a circular argument. Where do we finish it? And I suppose the last point is we've got obviously competency documents. If you're sitting somewhere else in the world and you want to access these competency documents that the Lancet Commission reported on, how can you take them and adapt them? Is there something you would suggest? Because I don't know whether you've taken them, Patrizia, and utilised them within your education work within the universities and that. I know you and Kathryn both work on the International Liver Foundation with EASL and that. So how are they being viewed as the only global competencies that we've got?
Just before anybody answers that, can I just say they are the most comprehensive competencies, but we do know that there are other smaller areas of work that has been done. So the Australian Hepatology Association have got some consensus guidelines that have been published between about 2019 and 2021, but more around very specific areas such as Hep B, Hep C, HCC, and also advanced liver disease. And also CARM, the Canadian Association of Hepatology Nurses, they do have again some specific competencies. Their most recent one actually just published very recently is around NAFLD as well. I suppose in response of the Royal College of Nursing competencies, they're there to be used. Anybody can go onto the RCN site and actually download a copy. Doesn't matter what country you are in the world. What it is then is about how do you adapt them for the nursing population within that specific country. What I would say is that I think there are core competencies that will cross-cut every country in the world. So things around pathophysiology, certain aspects of care, certain treatments from a EASL perspective and also the more AAH, CARN, ASL, D, etc., we might be able to look at a common platform, and then it might be for each country, should they wish to, and if they could, then they could personalise that further to their country, because what we know is every country treats liver nursing differently. We know in Germany there aren't any liver nurses as such. So it's interesting to see how that might be able to be adapted going forwards. I mean, I don't know what Patrizia thinks from a Swiss perspective and your Swiss Hepatology Association.
Thank you, Michele. I'm not sure if the Swiss Association knows about the competency framework, as it is primarily a physician and scientific association. For us, it's very useful, the competencies, but what we see is that we have to speak in patient situations. What is a complex patient, what is an easy patient, and how we can use these special skills within the situation itself. And then it becomes more attractive how we can use it. So we take the story behind of a patient, taking care of this patient, and then the competencies are quite easy to use.
Stephen, do you know whether or not the American nurses, any of the girls that you work with or your nursing team, do you have a set of standards that's not in a clinical trial protocol, for example?
Yeah, I'm not aware of any. Again, getting back to what we were saying earlier, I think we need to all come to the same seat, same table, and kind of work through a unified message of what we want to say and how we want to deliver it, because I don't think that exists. Certainly my nurses don't have anything like that.
I know there's advanced nurse practitioners, and they're very well regulated and highly regarded, and I've met a few of those. But
certainly our nurse practitioners and our physician assistants, the APPs, advanced practice providers, have an additional skill set, but even there's no prescriptive message that we're delivering. More importantly, even at the LVN and registered nurse level, we should have some sort of prescriptive message that we deliver that's uniform across the board, whether I give it as liver doctor focused on fatty liver, or my colleague who's a gastroenterologist seeing patients in a general GI clinic, or a primary care provider, or an APP, or a RN, or an LVN, or a medical assistant. They all should be delivering the same message. And unfortunately, again, as we heard from our patient at the top of the hour, that just doesn't happen.
But also, I think it's important to set different levels within the competencies as well, because it's everybody's job, right? It's the clinic nurses. It's not just about nurse specialists. Okay, the ward nurses are quite busy, but even if they were to have a level 1 signage of the competencies, they're at least able to define to a patient what fatty liver is. Okay, they're not comparing and contrasting it with other diseases, or they're not critically analysing it, but at least there's a baseline level 1 knowledge. Then you get to decide as a unit, do you want your staff level 1 trained, level 2 or level 3 trained? And an example of that is when I was managing nurse specialists at the Harley Street Clinic, there was times when I didn't have cover for certain specialities. So I might have an esophagogastric CNS, but I didn't have a HPB CNS to cover a certain HPB clinic. So we would give the esophagogastric nurse the competencies and say, would you mind over the next 8 to 12 weeks to bring yourself up to level 1 at least? We don't expect you to know everything, but there's a certain amount of knowledge that we do want you to achieve in 12 weeks so that you can cover that clinic for 6 months. So I don't think we can expect that every nurse that comes across a patient is going to be an advanced nurse practitioner and know her stuff inside out. Even ensuring that there's a level 1 knowledge base that frontline nurses can achieve is important as well.
I think that's one of the things that we tried to do with the competence framework, was that it's at different levels. So you could even come in as a practice nurse in primary care and achieve something within the suite of the different competencies, and then we built them up so you have that foundation, and then you went on to specialist and advanced care. And that's one of the things that's important, is that in any competence framework that there's flexibility. People can see how it relates to them, and also it's at the right level for them. I think you make a good point in terms of we can't make everybody a clinical nurse specialist, but what we can do is furnish them with some fundamental skills that can be achieved whatever the country across the world and whatever their role is as well.
Wonderful. And on that note, I'm going to start to draw you to a close because we could discuss this topic forever. So I'm going to go around the table again and I'm going to ask you to come up with one thing that you've heard tonight that's changed your practice or given you something to think about as to how we can move forward with liver nursing to develop a better understanding. And what would you like to see happen in the next 2 to 3 years? Michele?
This has been raised before about having a sort of global liver nurse community, and there were certainly certain people involved, such as from the BLNA, so the British liver nurses, the Canadians, the Australians, and also the Americans. But I think it needs to be more substantially thought about, and also to be able to offer something that we know that NAFLD, we know that fatty liver obesity is this huge problem across every country now, that maybe we do need to do something more globally as nurses to try and offer a platform for nurses to be able to access, whether that be knowledge, skill acquisition, understanding, etc.
Fantastic. Kate?
Well, one thing that really struck me from what Stephen was just saying was about the importance of thinking about other clinical specialties that we could involve to discuss patients with and situations. For example, the podiatrists. And that's a good point. What else do they need to know? One other thing that I'd be really interested in exploring in the UK would be to have a different type of formal liver course that's accredited. This has been talked about for years, and Michele is just creasing up with laughter here because it is definitely something that's been talked about for a long period of time. But I'm just wondering whether something that's based on those core competencies in that document that would be a great starting point to then be able to formally say that someone's achieved it at a certain level.
That's a whole programme on its own.
I know.
Yes, yeah. The major stumbling block is finance. Universities are very cash-driven now, and that's become one of the issues with the change in the UK, certainly around funding of CPD, etc.
I've got a quick final plea, really, to anyone listening who might be involved in designing clinical trials, and that's about making a real effort with inclusivity and people's languages. Because, for example, we have trouble recruiting to Hep B trials, on a slight tangent here, because people don't understand the patient information sheets because English isn't their first language, and there's no funding in the trial to have an interpreter. So if anybody out there is listening and is involved in clinical trial development of any sort, it's, to get a more representative population. It just seems to be completely overlooked, and no one who's a senior clinician involved as part of this seems to be picking this up either, which is a real shame.
Is that with commercial companies?
Yeah.
That's interesting, because I'm surprised that's getting through ethics without provision for that, because certainly for HCC, we're able to get the commercial companies. To be honest, whenever we have open trials, they've never been readily available. But I must confess, I've always contacted the drug company, and I've had it delivered in 20 different languages for every trial. But that's me reaching out to the commercial company. And to be honest, they don't have to provide it. The trust probably should, the local R&D department probably should have sorted that out. But the drug companies have been really good about it. For example, with CERT, the internal radiation, they sent me it in at least 20 different languages when I asked CERTEX to do that.
Stephen will be able to comment on that one.
Yeah, unfortunately, in the fatty liver world, that's not happening. We can ask for a Spanish consent for our Hispanic population, but generally that takes 6 to 8 weeks after initiation of the trial to get it translated and then IRB approved. But to Kate's point, there's a lot of disparities in healthcare here, getting that out to people of Asian descent. I mean, Asians have just as much fatty liver as Caucasians do, and a lot of them live in the UK, a lot of them live in the United States, and we can't recruit those people. Vietnamese, Chinese, Koreans, you name it, we're challenged by that. That's a good point, Kate, and one that particularly with our phase 3 trials, we need to be ready to pivot with a wide variety of languages at the ready. Louise, with that, I'm going to have to go because I keep moving on, but it's so nice to meet you ladies and all the hard work that you do every day. And I hope that this podcast is really a nidus for change and an opportunity for us to be more collaborative as we conquer fatty liver disease and again, leave that big fat dent on the planet.
Fantastic. Thank you. See you later. Bye. Patrizia. All right, Pam, you go next then.
No, I know, because it was just something I battled with so much with the languages. I must confess, I feel Kate's pain. But do you guys use language line? I mean, it's painful. I remember counselling patients through language line used to take me 2 hours.
And I think that's a particular British thing from that one. A lot of countries will use relatives.
It's a particularly British thing, but we have to give a code when we dial in. And if there isn't a code assigned to a study trial, then there isn't another one they can use. And it's just semantics, but it's really difficult. But it definitely excludes a population.
Patrizia, anything you're going to take away from this evening?
I take a lot with me, but I'm really aware also in this conversation all speak from collaboration and nurses are important. But honestly, we are here, we are doing research, but we need funding. Others have to see us and we have to publish our results and disseminate. And I really look forward that we get a little bit more proactively invited and that our results also get implemented in clinical practice, because we are really important and we try also on the European level to disseminate and to force nursing research. And especially in NAFLD or NASH, nursing care will be important, but if we will have trials on behavior change or something else, then it's quite hard to receive funding. So hopefully we can work also in this direction and can enhance the collaboration between all of us.
Fantastic. And Pam, what are you going to take away?
I'm probably not going to word this properly, but I feel like the British Liver Trust need to be beating the doors down at the universities, making it compulsory that these nurses are coming out just below level 1 trained and ready for the outside world of fatty liver and the pandemic that we're in with that. I think they're a very powerful organisation and you have huge parliamentary influence, and they could be a huge asset actually in all of this.
I'll feed that message back to the CEO there, Pam, who's also called Pam. So
yeah. We've been, because CERT was commissioned for HCC when NICE approved last March. There's only 10 centres in the UK and there's meant to be up to 30. And we've just been struggling to get them commissioned because NHS England is on its knees. And we've contacted Pam and I've just been really shocked and impressed with the support they've given us, and the voice they have is huge, and we're making progress finally.
Excellent news. And I would like to thank you all for joining me and having this stimulating debate, because I'm going to take away from listening to you all is the fact that when we start to develop clinical trials for NAFLD and NASH, actually using the competencies of liver disease might give our research teams and the people who design those trials an understanding of what they're dealing with and a basic knowledge for the education. Michele, you said it, by utilising the education elements, you can put your own programs together and develop it out. As we design clinical pathways to look at international management of NAFLD and NASH, we actually are working from something that's fairly concentric and focused, and we can add pieces to that jigsaw puzzle that are specific to an African location. Or I talk a lot about Australia and Indigenous health and Indigenous populations that are extremely prone to fatty liver disease and liver cancers and things like that. So that's the one way I'm taking it about. And I've just got a picture in my mind of Pam doing her video podcast of that and everybody seeing it around the world. That is the strength of coming together, is that as we design pathways for fatty liver disease throughout the world, we can design it with nurses key in every element and every area to help support our medical colleagues deliver better care, better outcomes, and get these drugs in. So I'd like to thank you all again for joining me and allowing that. And hopefully we'll be able to build. And for any of our listeners, please tune in. Please share it amongst your nursing teams. Surfing the NASH Tsunami reveals all sorts of data and information that your nurses need to know as well, because these are coming to help your care in the future. I'm going to hand it over to Roger, who will be topping and tailing this when he comes back from his holiday. But it's been an absolute pleasure to have Michele, Kate, and Patrizia with us, and Stephen, who's jumped. So thank you very much.
Welcome to today's business section.
Wasn't that great? I'm powerfully struck by the idea that we can make such better use of the informational and educational resources that reside in many corners and with many nurses and practices, but that lots of people who need to inform and educate don't know how to access or even don't know that they exist. I suspect you'll hear more about this issue in upcoming Surfing NASH episodes.
Please tell us how you felt about this week's episode. Don't be shy with your suggestions. It's one way you can help shape the future of this podcast.
All right, this is the second time we've done an episode on Surfing NASH that I did not host. Frankly, we took some feedback folks had about last summer's episode and organizing ourselves for this one. It's my goal this year to have at least 2 or 3 more episodes that I do not host, and possibly moving to 1 per quarter or even 1 every other month in 2023. Our team needs your feedback to make these episodes as valuable as possible. What else would you like to see in an episode that Louise hosts, or maybe Donna Cryer? Who else would you like to see host an episode, and what else would you like to see them cover? What about this episode worked? What didn't? Please send comments to questions@surfingnash.com. And if you would like to provide real-time feedback, send me an email address and some open times to schedule a video conference or a phone call, and I'll do it.
January audience numbers were crazy large.
Last time I reported on this 2 weeks ago, we had just passed our previous monthly record of 4,500 downloads, and we were looking at maybe something in the mid-5,000s by the end of the month. 6,000 seemed possible, but a little ambitious. So it turns out that at the end of the month, our final total was 6,907. Just to give you a sense of how large that number is, it surpasses any 2-month total in the history of this podcast through the end of the 3rd quarter last year by over 1,000. Or to look at it a different way, we projected to hit 85,000 total downloads this year, including downloads resulting from at least 1 sponsored podcast series we'll be announcing soon, plus a range of audience-boosting activities designed to boost us maybe 25% on a week-by-week basis. This month's pace over a year would get us close to 83,000 without any of that, and probably to 100,000 with all that in place. So clearly, we're delighted. Now, to talk business in the business section, what an odd idea. We've told potential sponsors for a while now that rates will go up when we install the customer marketing information structure end of 1st quarter, beginning of 2nd quarter this year. This month, we exceeded the audience targets that information structure should create, and as a result, the rates that we had in mind. If you're thinking about marketing preparation, brand building, or simply supporting a better informed world of NASH stakeholders, call us now. We're going to want to get it all worked out before the rates go up.
February promises some fantastic episodes.
We have firm commitments for the next 3 weeks and a tentative one for the 4th. Next week, we will be considering the question, just how large is the fatty liver population anyway? Looking at different methods used to create estimates in Germany, the US, and the UK. Jorn Schattenberg will be joining us to discuss his recently accepted, soon-to-be published work on Germany, and Ian Rowe will be discussing some of his team's work on the UK based in Leeds. We'll be announcing the US participant in the next day or 2. The week after that, Mazen Nuruddin and Terns Pharmaceutical CEO Sen Sundaram will join Stephen, Louise, and me to take a deep dive into the NAIL-NIT collaboration that we discussed at NASH-TAG. Sen brings to this conversation his experience in an earlier hepatology effort that produced fantastic disease insight and drug development progress for PBC, while Stephen and Mazen are key participants in the NAIL-NIT initiative, and Louise and I are here because we're here. The week after that, we're organizing an episode in recognition of Black History Month in the U.S. and its relationship to fatty liver disease. More on that next week. And then finally, our last February recording session, recorded February 28th, released early in March, is tentatively slotted to look at the recent research focusing on how hard it is for pathologists to find and agree on balloon hepatocyte cells. Sometimes it feels like every time we improve, that's improve with air quotes, drug development or drug approval criteria in NASH, we bring the law of unintended consequences crashing down on us like a ton of bricks. That certainly happened here, and this episode will explore that issue and whether there are better ways to achieve what the NAS scored balloon hepatocyte criteria were intended to do with fewer unintended consequences.
As you would guess from this week's download volume, there are a few treasures sitting in the vault.
Okay, there were 3 or 4 interesting trends in the vault this week. First, most of the increased volume was in episodes over the last 2.5 months. Of course, the Paris NASH Fibrosis Deep Dive 46.2 continued to get more downloads than anything else that was less than 6 weeks old, but the pace for that even slowed from being near 100 up until a couple of weeks ago to 50 last week to maybe 27 or 28 this week, so that's slowing down. Now, Conversation 51, which asks what from the AASLD 2021 event had the greatest impact, or if you will, maybe made the biggest dent in fatty liver disease, continues to score well, and this past week became the third item to exceed 300 total downloads, along with the Paris NASH that we just discussed in the post-FDA webcast episode from last January. Season 2, episode 61, which talks about the Splendor study and all of its conversations, received significant upticks this week, and Season 3, episode 4, our NASH-TAG 2022 wrap-up, has achieved the largest 20-day post-podcast download level in the history of the entire Surfing NASH. Finally, the full episodes from last August and September showed upticks in the range 7, 8, 10 per. So some people are going back and listening to those. And with that, let's sign off. Here's hoping that wherever you are this week, the weather's accommodating and spirits are high and people are happy. We'll see you next week with another challenging, interesting episode. This one a bit on epidemiology. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to surfingnash.com, and we will answer on the podcast or the website.